So I know he doesn't need an introduction to those of us in the myositis community, but I'm going to do one anyway. But we are extremely excited to have Dr. Aggarwal here today. Um, Dr. Aggarwal specializes in clinical and transitional research in inflammatory muscle diseases, particularly myositis and associated interstitial lung disease. Recognized as a leader in the development of disease criteria and outcome measures specific to myositis. He leads several international collaborations in the field, and he actively conducts clinical trials to assess novel therapeutic agents for myositis and holds key roles as a principal investigator or member of steering committee for several international phase 2 and 3 clinical trials in this area. Thank you, Dr. Aggarwal, for joining us today, and I will turn it over to you.
Well, thanks, Jessica, and thanks, MSU, for inviting me to present this webinar. So what I will do in next about half an hour to perhaps 40 minutes, review, the ABCs of myositis, right from the diagnosis to all the way to the treatment, and then perhaps leave next part of the webinar for more Q&A. I think I enjoy, hearing from patients and their questions more than a talk, but we'll start with the talk, which will get the groundwork laid. So I'm going to share my slides, and please, everyone who's listening, as you have questions in your mind, please start putting in the Q&A session so that we can start. Our team can start reviewing it. Okay, so let me see here. Are you able to see my slides? Are you able to see the slides?
Yes, we can see the slides.
Okay, great. So hold on for a second. Okay. Yeah, so let's see so if I'm able to advance it. Yep, able to advance it. You're able to see my slide moving forward?
Yes.
Good. All right. So what we will do today, this topic of today's webinar is, introduction to idiopathic inflammatory myopathies. As you know, we call it myositis in short. And most of the topic today I will cover, you are well aware of these topics because I'm teaching these topics, but you have dealt with these topics. You have personally have had experience with many of these things that we will touch upon today. So I appreciate, that you will obviously probably in some areas way more knowledgeable than I am in these on these topics. So first we will cover epidemiology and burden of disease. So let's start with IAM, or idiopathic inflammatory myopathies definition. It's a rare, heterogeneous group of autoimmune disorders characterized by gradual and progressive muscle weakness and inflammation with variable extramuscular involvement such as skin, joints, heart, lungs. All of those organs can also be involved, but the primary organ of target is muscle. Collectively, basically, there are many different types of myositis, including overlap myositis, necrotizing myopathy, dermatomyositis, and so on. As is seen in any autoimmune condition, females are more affected than males, 2:1. That ratio is seen in many other autoimmune conditions, such as rheumatoid arthritis and several other autoimmune conditions. That ratio of female is to male is generally preserved at 2:1. That doesn't mean the males are not affected. I've had many males with severe myositis, so don't get me wrong. It's just that females are somewhat more common than males. And myositis occurs at any age group. It occurs in patients who are kids. It occurs in patients who are in young adults as well as elderly. But the peak onset, the most common onset of age of onset is generally between 40, 45 to 60 years of age. And in kids is generally around 5 to 15 years of age. Another important aspect of myositis that we often talk about is it has a north to south gradient, which means it's a higher prevalence of dermatomyositis specifically because it involves skin as we get closer to equator. And that's been seen in multiple different studies. But overall, it remains a rare condition with overall incidence of essentially 11 per million person years. So that's about, very, very rare, makes it a, rare or orphan disease overall. Okay, so now second part is overview of clinical feature and diagnosis. All of you have dealt with many of these things. So for example, the first aspect is the risk factors. What are the risk factors? Well, female is more common than male, so obviously female becomes a risk factor. We have seen that patients of color are generally not only more affected, but also more severely affected. So that's also becomes a risk factor. Patients typically above 40 years of age are more commonly affected than less than 40 years. Those who have higher exposure to UV radiation and those who have autoimmune genetic background. For example, if you have a family history of autoimmune disease, then it's more likely you may have another autoimmune disease such as myositis. The patients have difficulty with multiple different motor tasks. Simple tasks that we take for granted, like going up the stairs, getting up from a chair, dressing yourself or shower, or getting up from a toilet seat. It's very simple tasks that you and many of us take granted are tough for our patients, and which leads to difficulty in their activities of daily living, which in turn leads to decreased quality of life. And all of that comes from essentially muscle inflammation leading to muscle weakness. But over time, when we treat muscle inflammation, what happens is sometimes, and in many cases, such as IBM and other disorders, patients develop muscular atrophy. And that's because prolonged muscle inflammation and damage may lead to atrophy. Once the muscle is atrophied, it is very difficult to revert it back. And we currently have no drugs that can reverse the atrophied muscle. So the point I'm trying to make here is don't let the muscle reach the atrophy stage. You want to treat it early and prevent those complications. And then there are many other common findings and complications that we will talk about subsequently as well. In terms of diagnostic tests, there are many tests that we use in our clinical practice. But when you first go to your doctor, the first and foremost, the most important thing your doctor does is take a detailed history and physical. Based on the detailed history and physical, most cases, not all, most cases, the doctor have a very good idea that this could be myositis. And then doctor runs some blood tests and some specialized tests to confirm that suspicion of myositis based on history and physical. One of the lab tests we use is called CK, or muscle enzyme, or is also called as CPK. This test is often elevated in patients with myositis. However, there are some patients of dermatomyositis or IBM where it may not be elevated. But mostly it's elevated. Um, then sometimes doctors like to do a test called EMG, or nerve conduction study, where they poke some pins and needles and little electric shocks to see how your nerves and muscles are functioning. And when they do that, they can detect the abnormalities in the nerve, in the muscle, or a neuromuscular junction. And based on that, they can say it's a primary nerve problem, a primary neuromuscular junction problem, or a primary muscle problem. And obviously, myositis should be primary muscle problem. Many doctors like to do muscle biopsy, and muscle biopsy is very helpful in really confirming the diagnosis. It is almost critical or essential in any patient without classic rash for dermatomyositis. So if you're coming with a classic dermatomyositis rash, biopsy will be helpful but not critical. But for anybody without classic dermatomyositis rashes or non-dermatomyositis conditions of myositis, such as necrotizing myopathies, polymyositis, antisynthetase syndrome, and so on, muscle biopsy is really the gold standard of diagnosis. Then doctors nowadays would do something called MSA or MAA. Basically, what it is myositis specific antibody is MSA, myositis associated antibody is MAA. These are a panel of myositis antibodies that your doctor would run because it tells us many different things. Number one, it tells us confirms the diagnosis if it's truly positive. Second, it tells us what organ could be involved. Third, it tells us about the prognosis and treatment responses. So very useful test to do. It's a blood test, more commonly available now than before. And sometimes the doctor might want to do a muscle MRI to understand the inflammation, to actually see on MRI the inflammation on the different muscles. Now, going forward, comorbidities and complications with myositis. As you know, myositis is a disease of muscle and multiple other organs, but these multiple other organs can be more problematic than the muscle itself sometimes. One of my most common things that I talk about is lung disease. I often say that my patients do not, they suffer from myositis. Their quality of life may go down from myositis, but they don't really die from myositis, and they die most commonly from interstitial lung disease. About 30 to 40% of patients with myositis may have interstitial lung disease. So I'm always worried about lung involvement with myositis or interstitial lung disease. So keep that in mind that the myositis can cause lung fibrosis or pulmonary fibrosis or interstitial lung disease. Then specifically for dermatomyositis, there's multiple fold increased risk of cancer. We've seen sometimes cancer and myositis get diagnosed together. However, in other times, it might be myositis and cancer has not yet revealed itself and will be revealing in next few years. So in those patients, it's important to do cancer screening to detect that underlying hidden cancer faster so that it can be treated at earlier stage. Then generally, we see problems with GI tracts such as dysphagia, difficulty in swallowing is a very common complaint that our patient would say. And heart, contrary to popular belief, heart is commonly involved in myositis. It's just that we are fortunate that even though heart is commonly involved, it's not commonly involved to a level of causing symptoms. So um, but in some patients, it may cause symptom and cause severe problems. So it needs to be evaluated on a regular basis. And then other issues that we see in myositis is infection and osteoporosis as a side effect for medication, high-risk pregnancy, as well as arthritis and arthralgia. So the disease burden. Now, this is much better known to the patient than myself, actually, because our patients, can talk about the burden of disease in much more details than I can. But basically, it boils down to difficulty in performing activities of daily living due to muscle weakness or other organ involvement. That's where the main problem is. Another problem that comes is from medication side effects. Sometimes we treat many patients with medications such as high-dose steroid, which may get patients temporarily better from myositis, but in exchange, we may give them a lot of side effects. So that's always a major area of disease burden. What kind of side effects the patient have to endure to get better? Third aspect is in terms of burden of illness is how much time they're spending in doctor's office taking medications, specifically going for infusions. As you know, certain drugs are only given by infusions, such as IVIG. So how much time are patients are spending in a doctor's office to get infusion, sometimes 2 to 4 days every month they may have to spend on infusion, along with time spent on physical therapy, exercise, and so on. And all of that results in time taken off work, which is obviously expensive for most patients. And not only that, in addition to that, dermatomyositis patient may experience painful, itchy skin rashes as well. So overall, if you look at myositis, the physician and patient, the patient burden of illness is very, very high as compared to any other autoimmune rheumatological or non-rheumatological condition that we see. So moving forward, you all know this very well that myositis is often misdiagnosed, misunderstood, and stigmatized. Actually, if I ask many of you to speak, each would have a story how they were not readily diagnosed or were misdiagnosed initially and then later on changed the diagnosis. And also when you talk to your family or friends and telling them about the diagnosis, they had not even heard of myositis. So they were really confused and didn't know what it is. And that kind of very demoralizing for our patients sometimes because they feel they're not well supported because nobody knows and understands their disease well. So that's why we have a responsibility to really increase the awareness of myositis, increase the education of myositis across the doctor community, and so on. So other things is, there's simple goals needs to be understand from the patient standpoint, especially goals which are defined by activities of daily living. So sometimes doctors are more focused on treating the underlying disease, which is what you need to treat for sure. But sometimes we forget to ask what the true goals of the patient is. Maybe the patient simply wants to walk again or drive again, or be able to go out in sun. Sometimes understanding patient's goals from treatment is important so that we don't overtreat or undertreat a patient. The role of patient support organizations, whether it's Myositis Association, UK Myositis, Myositis Support and Understanding. I recently have been on the medical advisory board of another organization called Myositis India, trying to promote the awareness and knowledge amongst the patient as well as doctor community. And for that, social media is a big tool, connecting patients to patients, connecting patients to the right doctor, providing resources and information, providing support. All of that are critical in the total journey of the patient from the diagnosis all the way till the patient gets better. So I think I'm really, actually really happy to see such dedicated patient support organization sprouting across the world, to support our myositis patients. So I actually believe every myositis patient should be member of one or the other patient support organization, not only to gain from it, but also to give, because patients can give back a lot to these support organizations. Unmet need. There's a whole laundry list of unmet need in myositis. And the biggest unmet need that I would say, from my perspective, is safe and efficacious treatment, safe and effective treatment. Because everything boils down to treatment. Do we have treatment? Right now, do we have treatment? Yes, we have treatment. But the part of the problem is they're not proven, they're not FDA approved, and they have huge safety concern. Each one of the treatment we give require a huge dose of steroid for long term. So we have treatment, but we definitely need much more effective and safer treatment options, which are proven in a scientific fashion and approved by regulatory agencies. The only treatment that we know is approved by FDA and other regulatory agencies, IVIG, for dermatomyositis. Now, there are many other unmet needs. For example, discussion about treatment about extramuscular involvement. Extramuscular involvement oftentimes can be more problematic than the muscular involvement. As I gave you an example of patients with interstitial lung disease. They are having shortness of breath and they are requiring oxygen, and they may die sooner because of interstitial lung disease. So it's very important that we control their interstitial lung disease. I've had patients who have muscle weakness, but they're more bothered with the skin rashes because the skin rashes is severe, difficult socially for them, as well as itchy and burning and painful. So many of the extramuscular involvements are important. We also need to develop, practice guidelines for diagnosis and management, because again, due to lack of information or awareness or knowledge about this disease among the doctor community as well. And also, include novel research in this area, we're doing more and more research, but patient perspective is becoming increasingly important, not only for doctors but also for regulatory agencies are asking researchers to include patient perspective in all research project. In fact, today we had a meeting on one such research project called MyPacer, in which we are basically is all about patient perspective in myositis. So basically, everything in that project is for the patient, by the patient, and from the patient. So It's basically we're not asking any questions from the doctor. We're going straight to the patient and asking, how's your disease? How does it affect you? What are the outcomes? Everything is sort of the whole research is geared toward patient perspective. And obviously, physical therapy and rehab and all have to progress. But overall goal is to have more effective and safe treatment without requiring significant steroid, because there's a huge over dependence on steroids. All right, moving forward with clinical presentation and diagnosis, this again, not a surprise to you, but basically myositis remains a disease of proximal more than distal muscle. Muscles affected predominantly are shoulder girdle, hip girdle, neck flexors, abdominal muscles, and the back muscles. So patients have difficulty in getting up from a chair, going up the stairs, difficulty in lifting the arm or lifting a gallon of milk, let's say. They also have difficulty getting up from a chair or getting up from a bed in the morning. So they have all these muscular problems, which lead to many uh, functional issues in day-to-day life. And then dermatomyositis, in addition, would have skin problem. These skin rashes can be painful, burning, itchy, really problematic for our patient. But as we discussed, several patients develop lung disease, many develop heart involvement, many develop malignancy and cancer, and then arthritis and some dysphagia, difficulty in swallowing, all of the other clinical manifestations that many of you have dealt with one or more of these clinical manifestations. Remember, not all clinical manifestation would come in every patient, thank God. So most patients get a combination of few clinical presentation or organ involvement. Skin rashes, there's a picture of heliotrope rash, which happens on the eyelid, Gottron rash, which happens on the back of the hand, mechanic's hand, which happen on the side of the fingers, and also skin UV light or sun sensitivity called photosensitivity can happen in our patients as well. In patients who have anti-synthesis syndrome or ASS, there is highest frequency of symptom is actually non-myositis or non-muscle. The number one organ involvement in this subtype of myositis actually is lung. Interstitial lung disease is as common as 70 to 80% of patients with anti-synthesis syndrome. Myositis is about 60 to 70%, and arthritis is about 50 to 60%. So this is a syndrome of lung involvement with interstitial lung disease, myositis or muscle involvement, along with arthritis or joint involvement. Coming to another subtype of myositis called IMNM. This subtype, fortunately, mostly involve muscle, so it doesn't involve other organs that well, except heart involvement has been seen because heart is also muscle. But not one good thing is it doesn't affect other organs, but the bad thing is it leads to severe muscle weakness acutely with very high muscle enzyme elevation. And because we can't get the treatment so quickly, and the patients have lost so much of muscle mass that they develop what we call as muscular atrophy very quickly. In my clinic, I would say if there are, handful of patients who come on wheelchair because their disease was diagnosed late and they develop a lot of damage by the time they seen us, typically most patients would have IMNM of those patients who are coming in a wheelchair. So IMNM can be very damaging, especially to muscle, leading to significant problems in the muscular component. So again, one of the entities that needs to be diagnosed and treated aggressively. IBM, I'm sure that there are IBM patients who are listening. IBM is a unique disorder that again doesn't lead to much of the extramuscular manifestation, but primarily involves the muscle. But the pattern of muscle involvement is quite unique in IBM. Patients typically develop forearm weakness with especially finger flexion weakness and wrist flexion weakness. They also develop preferential involvement of quadriceps, leading to quadricep weakness or ankle or knee extension weakness similar to the hip flexion weakness. And they typically have asymmetry from side to side and so on. Difficulty in swallowing is a major problem. It's a very slow progressive disease. The only good part in this disease really is that doesn't involve the extra muscular involvement is rare. But other than that, it's a pretty severe and debilitating disease. Unfortunately, we don't have good effective therapies. Even with the caveat of steroid, actually is not good for patients with IBM. So IBM remains the top amongst the myositis as an unmet need that needs to be addressed. Now, we did talk a little bit about myositis-specific antibodies, and there's a whole list of different myositis-specific antibody within different disease area. For example, dermatomyositis has about 5 to 6 autoantibody subtype. IMNM have several autoantibody subtype. IBM have only one antibody, and antisynthetase syndrome actually at least have 8 different autoantibodies. Um, how are these autoantibodies helpful? Well, number one, if you truly have an antibody, and it's not false positive because that's also a problem in autoantibody determination. But let's say you have truly positive myositis-specific antibody, that nails the diagnosis. So you really don't have a diagnostic dilemma or uncertainty if you have one of the antibodies. Second thing, the way it helps is each autoantibody has a unique clinical features. So, for example, TIF1 antibody is strongly associated with cancer. Jo1 antibody strongly associated with lung disease. So typically each of the autoantibody has its own signature of organ involvement that could be expected from that patient. And that really helps to monitor that organ aggressively and treat it as soon as there is any clinical involvement of that particular organ. Um, so the other place where antibodies help is that we know that certain antibody respond to certain treatment differently. So for example, if I have an HMGCR antibody, I might prefer IVIG, whereas if I have SRP antibody, I might go for rituximab first. So those antibodies are really helpful. And also, it also helps in prognosis. So some antibodies have poorer prognosis, some antibodies have better prognosis. Give me 1 second. My daughter just came in my room. I just have to address her, otherwise give me. Sorry about that. All right. Okay. So going to the disease management and emerging therapies. So you Okay, here. So first of all, we need to address the goals of treatment. And for me, the goal of treatment might be different than for my patients. So I think it's very important that the doctors talk to the patient and patients should talk to the doctor about their goals of treatment. Because the treatment is not straightforward. It's not like all treatments are equal. There are treatment side effects, there are long-term complications. So I think it's important to discuss the treatment goals. But typically for a doctor, a treatment goal is remission. They're trying to quieten the disease that it kind of goes into long-term remission. But in order to do that, they might need to use, a lot of different combinations of drug, which might have its own side effects. So that's why it's a balance between the side effects and amount of effectiveness you want to achieve in myositis. So treatment goals are important. So there are many treatment goals, for example, resolution of pain, improvement of strength, improvement in quality of life, controlling inflammation, preventing complications, and obviously the ultimate treatment goal of remission. Now, in terms of treatment, so there's a good and a bad news here. Good news is that we do have treatment for most myositis subtype except IBM. So that's a good news. That means if the patient present to us, we won't say there is no treatment available. We have several lines of treatment that we'll discuss in a minute. I think the problem is that most line of treatment require high dose of steroid and a taper for long term, and that lead to significant side effects and morbidity problems for our patients. So that remains a severe unmet need, that treatment which is effective and safe and do not require too much of prednisone. With that, I think still the first line remains the prednisone, because without that, we can't get the patient's inflammation under control too fast. Then azathioprine or methotrexate, I would not say Aza is better than methotrexate. I would say, in fact, opposite or about the same. Then the third line is a combination therapy. That means you need two immune suppressive drugs, as we know from rheumatology and all other rheumatological autoimmune diseases. Combination immune therapy is better than a single therapy. Then we have drugs like mycophenolate, tacrolimus, or cyclosporin. And if that fails, sometimes we have to use drugs like rituximab, cyclophosphamide, and tacrolimus combination. But along with all these first, second, third, and fourth line, we have a treatment called IVIG. It's an excellent treatment specifically for dermatomyositis. Can be used as a first line, second line, third line, or in a combination to these immune suppressive drugs. Anytime you need a help for treatment, IVIG can be your help. But there's one problem with IVIG. It's logistically very challenging. It's expensive. Insurances don't like to approve it, and it requires long period of time. It has a significant side effect burden, including headache, nausea, vomiting, and so on. But it also have increased risk of blood clots. So those who have increased risk of blood clots to begin with cannot get IVIG for that reason. So IVIG, although is a great treatment for dermatomyositis, it comes with its own caveat. Also, exercise is really a great treatment. It's actually anti-inflammatory in myositis. So I would strongly encourage everyone to start exercising from the day you get diagnosed all the way till you are in remission, because exercise itself is a treatment for myositis. Then if everything fails, then, there are many other, experimental therapies to consider. But here I would take a pause and make a pitch for patients to join clinical trial. There are many benefits that most doctors don't talk about while giving you clinical trial as an option. And I'll tell you the number one reason my patients, if I ask them why they have joined the clinical trial, the number one reason that they have joined is a greater good. That means they said that the fact that if I join the study, I might be able to inform the future generations of patients who may develop myositis whether this drug is effective or not. In fact, 3 patients that I enrolled in IVIG clinical trial, every time I meet them, they thank me only for one reason, for me to put them in this clinical trial, not because they got benefit from that treatment, but more because they felt that since IVIG got approved for several patients, they felt they are part of that approval. Because of them, which is true, because of them, the IVIG got an approval for dermatomyositis that is now being used for several thousand patients across the world. So they felt really good about the fact that they are a key person in establishing that. Other reason that patients join clinical trial, and I think it's very important to understand, is it's their own benefit. Oftentimes, when a doctor offer you a clinical trial, they're offering a clinical trial with with deep understanding of what this drug do, with extensive plan of monitoring. So most patients that I enrolled in clinical trial actually benefited from clinical trial, and most clinical trial have open label arm. So you may get a placebo or treatment for the first phase of the study, but remember 2 things: that one, in the second phase of the study, you will get active treatment. And the second thing is, if you happen to get placebo and you're not doing well, your doctor still has the ability to take you off the trial because you're getting worsening. But many trials, there may be allowance to actually do rescue medication. So being in a trial, and if you get a placebo, is not that bad, because one, you may get a treatment down the lane. Second, your doctor's not going to let you go worse. If they're getting worse, they will give you some rescue treatment and take care of you. But overall, most patients actually, that in my experience, have been very happy after joining clinical trial. And last but not the least, I will say, when patients join clinical trial, they get monitored 10 times more than a regular clinical care. So basically, there's a lot more eyes on you. There's a lot more people monitoring your disease activity. So they're not going to let you go down. The moment they see there's a side effect or the patient not doing well, they're going to intervene right then. So there is a lot of value that can come from joining clinical trials. Okay. Um, Last but not the least, let's just summarize. I hope we, uh, convinced that, reviewed it very well, that myositis is a heterogeneous, rare autoimmune disease which primarily affects muscle and multiple other extramuscular organ systems such as skin, lung, joints, and others. Formal diagnosis require a detailed history and physical, but also many other extra tests, such as lab tests, such as muscle enzyme like CK or CPK. Other lab tests include myositis-specific antibody, sometimes skin or muscle biopsies needs to be done, MRIs and EMG needs to be done. And based on all the information, your doctor would decide, or based on the totality of the evidence that's presented to the doctor after these tests, that they say, okay, I'm 100% sure, I'm very sure that you have dermatomyositis or polymyositis and so on. Also, remember that currently we don't have good treatments. We have drugs that we give to get you better, but that doesn't mean they're the best drugs for you. We've been using it, but there's no randomized controlled trial to prove those drugs except for IVIG. So keep that in mind, that we need better randomized controlled trials to prove a drug works or not. And problem of current treatment is they require a lot of concomitant steroids to get you better. So we are hoping that we have made a case for novel therapeutics with high effectiveness and low side effect burden for our patients, and we are really hopeful that this significant unmet need will be overcome in next subsequent years. And this is just a link on for Global Trial Finder for clinical trials in myositis. So I encourage all of you to encourage MSU team to share this link with our patients, and they may see which clinical trial, if they are in need, they best fit for. With that, I will stop here and take any questions.
Okay, thank you very much for that amazing presentation. We have a couple questions in the chat or in the Q&A, but we also had some that were submitted when people registered. So the first one is, any updates on inclusion body myositis specifically?
That's a great question. So actually, there is an update. There's a clinical trial by a company called Apcuro. They have a drug. What this drug do is they kill a very specific small population of cells in our body. These cells are supposed to be pathogenic for IBM. That means these cells are the ones that are causing damage. These are immune cells, your own cells, but they are specific cells that are causing damage to your own muscles, leading to local inflammation of the muscle. So what this drug does, it basically kills only those bad cells. So we believe it should be safe because it's only killing a very small uh, population of immune cell. So there's a trial that is ongoing. We recruited about 9 patients in that trial, and we are very happy that our patients were able to avail that trial. But I think right now they're on hold because many patients have already enrolled in that study. But we are hoping that next year we will have some results on it. And then there's also a drug called rapamycin or sirolimus, which was studied in a phase 2 study. And what happened in the phase 2 study, The primary outcome was negative, but that could be because it's very difficult to assess outcomes in inclusion body myositis specifically. But several of the secondary outcomes were strongly positive. So that led to a conclusion that we need a phase 3 study, which is currently ongoing, but there are only a couple of centers in US. It's mostly being run in Europe and Australia right now. So those are two specific ones I know. I know many other drugs in development, but nothing at a clinical trial stage.
Awesome. Thank you. That is very exciting. Um, Next question. Does untreated myositis lead to inclusion body myositis?
No, that's not true. You either have inclusion body myositis or you don't. You don't go for dermatomyositis or inclusion body myositis. There is an overlap though. I have handful of patients that may have a dermato and IBM or necrotizing and IBM, but it's only very, very few. Mostly you either have one or the other subtype.
Got it. Thank you. Um, is there a treatment for statin-induced immune-mediated necrotizing myopathy? Specifically, their wife was diagnosed in 2019, treated with methotrexate and prednisone. CK is rising again. What could be done?
Well, it's actually the statin-induced necrotizing myopathy respond very well to IVIG and also to rituximab. So if methotrexate and steroid are not doing the magic, I think I would strongly recommend you to talk to your rheumatologist or neurologist and discuss with them the risk and benefit of doing IVIG or rituximab in your case. It's very difficult for me to recommend anything in your case because obviously I don't know you. So there may be parts of your history that needs to be understood. But at least with this through this session, you gives you enough confidence to talk to your doctor and see whether these will be good drugs for you or not.
One. If clinical trials halt or slow muscle loss in IBM, is it possible to rebuild any existing muscle?
The
And then
Yeah, go ahead.
And then the second part of that was also their CK level has been consistently at 1500 since their diagnosis of IBM 6 years ago, but it was just measured at 500. Is this a good sign?
Yeah. Well, let me answer. The first question was that, okay, I'm blanking on the first question.
Is it
Uh,
possible to rebuild any existing
yeah, okay.
muscle?
Yes, it is possible. I will tell you, I have had handful of patients who through really good aggressive physical therapy and exercise been able to rebuild. But it's not possible for most patients. It is very difficult. What is possible though with regular exercise is you can maintain the current muscle. That is definitely possible. And I would strongly encourage you to everybody to have that as your goal, to be able to maintain your muscle mass and strength at a current level. I have had a handful of patients who did very aggressive physical therapy, and we were able to overcome. The logic is very simple. When IBM is causing slow destruction of your muscle, exercise builds up the muscle. So, if you are able to overcome that slow loss, you might be at benefit. But at the very least, regular exercise, you should be able to match up to some extent. It's still going to progress, but it will progress at much lesser or smaller decrease rate, which will, because it's progress over years, will give you several more years of that functional level before you decline further. And I think your second question was about CK. It's a very tricky situation. So I'm going to take your example. Since you were at 1500, 1500, 1500, and then dropped down to 500, that may not necessarily be a good thing because it may just reflect that you've lost so much of muscle mass that there is not much muscle mass left to produce CK. So that's one scenario. Another scenario could be that truly you got some benefit from, maybe you're in a trial or some study and you truly got benefit and it actually declined, the muscle inflammation declined. But also sometimes because IBM is a balance of muscle inflammation and damage, sometimes inflammation will go down naturally as a natural course of the disease. Not because you're treating it, it's just because the damage is taking on more. So you see this when the damage is more, now you develop atrophy, and then the muscle inflammation levels will go down. That will then decrease the CK. So there are many reasons for your CK to decline. I would not necessarily mean, it does not necessarily mean that you're getting better in IBM. In other forms of myositis, typically all the three things I said still apply, but it typically may mean that you're getting better.
Excellent. Okay, can IBM patients with moderate to severe dysphagia benefit from IVIG or subcutaneous IG?
They actually, the best treatment for dysphagia is IVIG or subcutaneous IG. So if you're on that, you're the best treatment. But there's a problem. The problem is that dysphagia is very slow to respond. So you have to be very patient. Average time of maximum muscle improvement on IVIG is typically 6 to 8 months. But average time for dysphagia, I actually don't even know, but if my memory serves me well, is above 1 year. So, it takes much longer to recover.
Okay. Inflammation and diet choices. That's the question. That's how it was worded. So I guess they're
Inflammation.
wondering if diet choices can help with inflammation.
Yeah, well, there's not much data. So I don't like to comment on something that I don't know. But at least we know there is no particular diet that is a risk, and there's no particular diet that is a treatment. Okay. So let's start with that. But we know a healthy diet will be better than an unhealthy diet because healthy diet affects the muscles differently, and you're trying to recover your muscles, you're trying to grow your muscles, you're trying to build your muscle. So healthy diet is definitely better than an unhealthy diet or high calorie diet. So keep that in mind, specifically when you're exercising. You need a good diet, good nutritious diet to really build up your muscle. So those are the main ones. And also remember, because you're going to be on steroid, most people are on steroid with this. High calories can be, or high fat diet can be a big problem for you because you're already getting steroid, which leads to weight gain and other problem. So overall, my advice is healthy diet is the way to go. There's actually a study done on Mediterranean diet that is very useful generally for autoimmune disease patients because of various benefits of Mediterranean diet.
Thank you. This person's had rituximab for 17 years. One time a year was sufficient to keep their disease under control. New rheumatologist took them off of it because didn't want them due to the length of time and the fungal infection in her lung at the time. Do you have any other options because nothing else has worked?
So rituximab is a great treatment, but the problem with that treatment is it is required multiple times long term. And what happens is over time, rituximab decreases our immunity. And over time, it actually may also decrease in the immunoglobulin level, which leads to infection. And ultimately, in many cases, we have to stop. I'm actually surprised you went for 17 years on it. That's quite a long time. Most of my patients are not able to go so long. But once you start to develop infections, it is clear that giving rituximab is of risk to you. So I think your doctor did it right. The question is, what else can you do? And it's very difficult for me to answer because without knowing all the history. But there are many other treatment options, such as IVIG and others. But there are also clinical trials that you could participate if your disease happens to be an active disease.
Okay. Recommendations for palm and feet cramping.
Recommendation for what?
Palm and feet cramping.
Cramping, huh? That's a tough one. Cramping typically comes from various different reasons, not only myositis. So what I would advise is to make sure you're not having magnesium deficiency or not having thyroid problem or not having other problems that could cause cramping and not only myositis. The second thing is another common reason in our day-to-day life for cramping is lack of stretching. When muscles get tighter, they cramp easily. Easy stimulus can cramp them. So range of motion and stretching exercises can actually benefit the cramps per se. And last but not the least, there are muscle relaxants such as Flexil that might be able to help some patients.
Okay. Um, this one was no autoantibodies and no rimmed vacuoles. So how could this be diagnosed as IBM? What else could it be?
Excellent. So it seems like your doctor diagnosed you with IBM, but there's no autoantibody and there's no rim vacuoles. That's what I'm trying to that's what I'm understanding. Actually, rim vacuoles are absent in 30% of the cases on IBM. So you could be one of them. Autoantibodies are not that great in IBM. Um, the fact that your doctor diagnosed you with IBM, that means you have the right classic clinical features of IBM. To me, that would become with the forearm weakness or finger flexion and wrist flexion weakness, quadricep weakness. So I think clinically you might fit very well with IBM, and your biopsy might be consistent with IBM, even if it's not diagnostic of IBM, given lack of rim vacuole. So I think it is difficult for me to say the diagnosis is right or wrong, but I think you may want to ask your doctor how the diagnosis of IBM was reached if you're in doubt. But typically, the diagnosis of IBM do not require autoantibody presence and do not always have rim vacuoles. There are many other clinical features on biopsy that can indicate predominantly inclusion body myositis.
Excellent. And I'm going to ask a follow-up question to that when it comes to autoantibodies. Something that we see very common in myositis chats and stuff is people will have a positive, muscle biopsy, but have no autoantibodies. And then they will ask the question, well, do I actually have myositis? Could you address autoantibodies and the lack
Yeah.
of having any, please?
So, unfortunately, the autoantibodies are really powerful, very helpful, but it's only present in about 60 to 70% of patients. So that means 30 to 40% of patients you're going to be negative. That doesn't mean you don't have myositis. That just means you don't have an antibody. If you don't have an antibody and you have dermatomyositis, typically what we have seen is the accuracy is very high. If you don't have an antibody and you have polymyositis or any of the non-skin myositis, such as non-dermatomyositis, then I think, and you have antibody negative, then the doctor should rely strongly on your clinical feature, EMG, MRI, but most importantly on your muscle biopsy before confirming your diagnosis.
Fantastic. Thank you. What are the three most promising drugs being tested now for dermatomyositis?
That's a great question. Tough one for me, honestly, because I deal with many clinical trials, and almost all clinical trials are testing different, really good high therapeutic target. But there are some things that I can share. For example, patients who are receiving anti-FCNR treatment, such as treatment, there are two trials ongoing, one by Arginex and one by Janssen. Both of the drug, what they do is they block a receptor of immunoglobulin that leads to decrease in autoantibody levels of the patient. And we believe that decrease in autoantibody level may translate into clinical improvement. So that's a mechanism of action or the trial or the drug that I really like. Another one that I really like is anti-interferon. The companies have developed antibodies against interferon, so they can actually block the interferon. And as you know, dermatomyositis patients have high interferon signal. So belief is that interferon is what's causing the disease. So if you block that, that might actually help with the disease. And then last but not the least is a drug class called JAK inhibitors or JAK-TYK inhibitors, which also, through a different pathway, block interferon signal.
Wow, thank you. That's exciting. Um, are there any clinical trials using microbiome controls?
There is there is no clinical trial that I know that using microbiome, but I know there's a study funded by TMA a couple of years ago on microbiome studies. So, but I'm not sure the current results of that study.
Okay. Um, Sorry, trying to scroll through. Can you comment on off-label drugs that are good for DM and with IDL?
Off-label drugs that are good for DM and
And with IDL, with interstitial lung disease.
I, I ILD. Okay,
Sorry, I dyslexic. I totally said that backwards.
no worries. Off-label drugs. Huh. Honestly, all the drugs we are talking about are off-label except for IVIG. So in patients with DM and ILD, my top choice for off-label drug would be rituximab.
Okay. um, that one, sorry, there's a couple in here that are very specific that says I have been diagnosed with DM negative markers with ILD. EMG test normal. I have dysphagia. Could you comment on this?
I have dysphonia. So
Dysphone. Oh, sorry.
that's okay. Dysphonia is a common clinical feature for myositis. It's basically what happens is the voice gets affected. And our patient tells me is when they get up in the morning, they're able to speak very fine. But as the day goes by, their voice gets muffled and soft and they're not able to speak. Or even in a single conversation, they start good, but that over time they get tired. And that's a classic thing that we see with muscle inflammation or muscle weakness. Basically, your voice box is supported by muscle, and since those muscles might be affected, your voice box get weak very quickly, leading to difficulty in speech, and that's what's called dysphonia.
Thank you. How do you define refractory? Doesn't react favorably to medications, particularly favorably. If you get
No,
better,
refractory basically has multiple different definitions, but basically lack of complete improvement is considered refractory. So whether you got partial improvement or you got no improvement or you got improvement but had to stop the drug due to side effect, or you got better, but then when the drug was tapered, you got flare, whichever way is considered as refractory. So basically refractory is anything which is lack of complete treatment.
okay. In your experience, what percentage of patients do not exhibit skin manifestations with dermatomyositis? Um,
Dermatomyositis, senior dermatomyositis, which basically you have dermatomyositis phenotype, but you never had a skin rash. It's tough to know the exact numbers because many of those remain undiagnosed or get diagnosed with, later on. But my guess is that that's entity of dermatomyositis, senior dermatomyositis. That means you have a dermatomyositis clinically, but you don't have the rash of dermatomyositis, is probably seen less than 5% of cases.
okay. Um, is the NXP-2 autoantibody uniquely associated with dermatomyositis?
Yes.
Okay. When would you consider putting a patient on IVIG and when would you take them off?
Great question. So, typical regimen of IVIG is about 18 months to 24 months. It takes about 6 to 8 months to get better on a peak dose of 2 gram per kilogram. When we decrease the dose to 1 gram per kilogram for next 6 months. Once the patient is doing well, we decrease it to 1 gram per kilogram every other month for next 2 or 3 cycles. That takes you to about 18 months. And then either we stop it at that stage or we occasionally take it to every 3 months and then stop it. So typically, I would say anywhere between 18 to 24 months is an ideal regimen, length of regimen for dermatomyositis for IVIG. However, note, some patients not able to tolerate lowering the dose or the interval of IVIG, and they remain on IVIG even years after the disease. All right.
Okay. My brother has recovered beautifully from NAM after 6 months of IVIG and PT. He stopped the IVIG. What is the probability of returning symptoms?
6 months is on a shorter side for IVIG. I would have loved that the patient was tapered down on IVIG first before completely stopping it, but 6 months, so some patient might go in remission. It is difficult to say what would happen to that patient, but typically I would say if the patient gets flared up, it will be clear that the treatment could have been truncated a little sooner than ideal.
Okay. This question just popped in the chat, and I don't want to not address it, but they said that they had ILD, but their last exam showed no evidence. Does that mean IVIG cured me?
Well, there could be many things. One is that there may be treatment improvement. That's possible, but there also be a possibility when you are first diagnosed, you had some ILD features because you had a lung infection or you were not breathing that well. So you have what we call as atelectasis at the basis. That means the diaphragm was pushed up and led to collapse of the lung that look like fibrosis but wasn't fibrosis. There are many reasons for that. So I would not be able to tell you exactly, but yes, there are improvement on ILD patients. On ILD topic, I would strongly encourage everybody to, if you have ILD, to strongly consider the MINT trial or myositis in ILD nintedanib trial, because what we are trying to do is combine immune suppression with antifibrotic drug for patients with ILD, because we believe that the combination of immune suppression and antifibrotic drug actually is beneficial, better than a single agent. So if those who have ILD on the call, please consider participating in MINT trial, because you can participate from anywhere in the country from the comfort of their home. You'll get drug delivered to your home. You'll get a nurse come to your home, take your blood labs and everything. So it's a very patient-oriented study for you to participate. And I'm happy to share I'll just shoot my email for those who may want to consider themselves for this study. We have a whole protocol where we will evaluate you to see whether whether you are the right fit for the study, and whether if the study will benefit you.
Excellent. And also, there are, I was going to say MSU has put out information about the MINT trial as well. So you can always go to our Facebook page and get information there for the MINT trial as well. What do you feel are the most effective ways to educate physicians other than our one-on-one conversations with our own physicians?
That's difficult. It is difficult for patients to educate physicians. I think if the patient may want to share opportunities of webinars and series that MSU held or TMA held, that's probably the best way, because doctors typically are, unfortunately, a very egoistic community. And I think they like to hear from their peers or from their mentors more, or they understand that better. So I think the best thing the patient can do is guide them towards the right source of information. For example, if there's a webinar or there is a lecture series, in telling your doctor about it might be helpful.
Excellent. This person has CADM, and they have a burning and pain sensation on the back of their thighs, buttocks when they sit. It's not itchy and it's not a rash. Have you had DM patients with this?
Burning and itching sensation on the muscle is actually a very common complaint. Burning specifically, itching sensation generally comes with rash, but burning pain of the muscle is actually quite common, quite common in myositis. That doesn't mean the myositis is active. It is seen in active disease as well as inactive disease.
Okay. And then they're asking if you can clarify your statement that IBM has no cardiac or pulmonary impact. What about the impact on the diaphragm's inability to support complete inhale exhale functions?
No,
Is
I
that
don't think I would say that IBM do not have impact on lung or heart. I think that'll be a wrong statement. I may have, I don't know when I made the statement, definitely not today, but I may have made a statement that involvement of lung into parenchyma as is more common in non-IBM patient. IBM patient affects the lung from the diaphragmatic weakness standpoint, not so truly the lung itself is not a problem. It's just the lung respiratory muscles are weak. That leads to, but whereas in dermatomyositis, for example, lung structure itself is attacked and causes inflammation. So may have wrongly spoken. I apologize. I did not mean that the lungs are not affected by IBM or heart is not affected by IBM.
okay? Yeah, because then their follow-up question to IBM is there actually no cause and effect connection between IBM and cardiac or pulmonary diagnosis?
No, there is definitely cause and effect reason. It's different. Uh, the way it affects the lung is different.
Okay, excellent. Um, what would you recommend for muscle pain?
Muscle pain is one of the most important point of the muscle pain is to see if they have active muscle disease, because if they active muscle disease and they treat the active disease itself, the muscle pain should get better. But then some patients have muscle pain despite inactive muscle disease or residual disease. In those patients, basically the best treatment for muscle pain is exercise. That's slowly rebuilding the muscles, because you're having muscle pain because the muscle structure, ultrastructure has changed because of your previous myositis. So now the same things are more sensitive to your nerve endings. So with the exercise, you can rebuild the ultrastructure to where it should be, and that will decrease the pain thresholds of your muscle.
Okay. Um, please compare relative efficiency of injectable methotrexate versus oral tablet.
That's a great question, but we don't have any data on myositis. We have data on rheumatoid arthritis where injectable methotrexate is 30% better than oral methotrexate, but we don't have the equivalent data in myositis.
Okay. Um, so okay, sorry, the person that was asking all the questions about the IBM, they were just commenting that it's because they have several diagnoses in all three of those departments in their healthcare. So, okay. Let's see. And we've already answered this one. I have pityriasis rubia pilaris, excuse me. Are you familiar with it? And they also have DM and ILD overlap.
I'm not sure. Pityriasis rubia. I'm actually not very familiar with this condition.
Okay.
I know the condition. I just don't know how much of it that condition is an autoimmune overlap with dermato. So it's tough for me to answer that. I've never heard, or it has never occurred in any of my dermatomyositis patients.
Okay. I would so you've put your email in the chat. So they had a follow-up where they were possibly wanting to set up an appointment with maybe you and their doctor. So I'll direct that person to your email. And that may or may not be something you can do. Um, are there exercises or treatment to prevent onset of dysphagia in IBM?
There are actually really good speech therapy exercises. I don't know those exercises myself. You would have to be referred to a speech therapist. The speech therapist can teach you really good exercises to prevent and actually improve your dysphagia just by exercise itself.
Excellent. What is there to help with fatigue as well as super sun sensitivity?
The fatigue comes from two reasons in myositis. One is active disease or inflammation. So first and foremost is to make sure you don't have active inflammation and your myositis is inactive or quietened. The second reason muscle fatigue comes, the same reason muscle pain comes, is damage to ultrastructure of the muscle, and that can only be rebuilt again by exercise. So those are two reasons you have to keep it separate. I have patients who come in with fatigue and I'm treating them with immune suppression. Another patient, I'm not saying you should not get any immune suppression. It's just because fatigue comes from two different sources.
Excellent.
I do have to leave in 3 minutes.
No problem. All right. Let me, okay, let me just kind of scroll through here and um, I'm assuming this is going to be something that would have to be answered by a physical therapist, but is there a type of exercise that's recommended for people who have muscle fatigue as well as interstitial lung disease?
Yeah, so for interstitial lung disease, I would strongly recommend to do pulmonary rehab. There's a specific pulmonary rehab you can get referred to and they can do. For other type of exercises, I think you really need a couple of things you can do is you can watch some videos on IBM, but also educate your physical therapist about IgM through those videos. And then they can actually help you to, develop a regimen for you.
Excellent. Is it possible for IBM to go into remission?
IBM is, we don't have any treatment. So if the IBM went into remission, you're really lucky. That perhaps could be a situation where you never may have had IBM, or you may have had a very mild form of IBM that got into remission. So those are the possibilities. But in my experience, I've not seen it, that it went into remission. That means it got better.
Got it. They have NDA5 with early ILD. They're receiving rituximab, and they currently have prednisone and immunosuppressant. They're asking when can they plan for a baby?
You can plan for a baby once you're in inactive disease state for about 6 months or more. That's the best time when your disease is under control, and it stayed inactive for about 6 months. That's a good indication that your disease will not progress or flare up. It can still though, but the risks are lower at that stage.
Okay. Let's see. Can IVIG be used with rituximab?
Yes, why not? Absolutely, we use it all the time.
Okay. And then
Because I have a hard stop at 4:15. I have another
no
meeting.
problem. Not a problem. We appreciate your time. We thank you and then you did put your email in the chat. So if people had,
Yeah.
they could always go that route. But I think we covered most of it. A lot of the other ones that were still in there, we've already answered. So
Thank you.
again, Dr. Aggarwal, thank you very much for your time today. We appreciate it.
Take care.
And thank you to everybody who attended.
Bye.